Welcome to this podcast from the Medical Journal of Australia. My name is Sam Hunt, the MJA's News and Online Editor. Today we're discussing HIV in Australia, including the latest epidemiology, developments in treatment, and the path to elimination. We'll also explore how genetic-based surveillance is helping researchers track the disease. My special guests have researched this topic and join me now. Dr. Phillip is a Senior Research Fellow at the Kirby Institute at the Faculty of Medicine at the University of New South Wales, Sydney. He has major research interests in HIV testing and monitoring and evaluation of HIV prevention programs. Dr. Francesca Giallonardo is a Senior Research Fellow at the Kirby Institute, also at the Faculty of Medicine at the University of New South Wales, Sydney. She's a trained virologist and expert in molecular biology, with major research interests in evolutionary biology, disease emergence, and genomics. Dr. Keane and Dr. Giallonardo, thank you both so much for joining me today.
Thank you. It's great to be here.
Thank you, Sam.
Dr. Keane, I'll start with you. Can you please take our audience through the latest statistics on HIV in Australia?
Sure, Sam. Well, first of all, Australia is really what's referred to as a low prevalence country with a concentrated HIV epidemic. That means that the proportion of the general population with HIV is very, very low, but that HIV is concentrated among some groups like gay and bisexual men. But what we've seen over the last few years is a really significant decline in new HIV diagnoses. So there's been a 46% decline between 2013 and 2022, from 1,037 new diagnoses to 555. When we look at the population rate, it's fallen slightly more. So in 2013, the population rate was 4.5 per 100,000 new diagnoses. It's now down to 2.2 per 100,000 new diagnoses.
And Dr. Keane, the HIV task force was set up last year by the Federal Department of Health to renew efforts to achieve elimination of HIV in Australia by 2030. How is Australia faring? And what stands out to you from the report?
Yeah, sure. What you just referred to, the target to, or the goal to achieve the virtual elimination of HIV transmission, what that means is that there should be by 2030 a 90% reduction in new HIV diagnoses compared to a baseline, which is based on 2010. And what the task force was about was Minister Butler formed the task force to inform him and the government about where we've done well and where we can do better. And some of the recommendations they made in particular were that PrEP, the use of pre-exposure prophylaxis for HIV, which has really been a game changer in terms of HIV prevention. It's a 100% effective prevention strategy when used as directed. And it's been very successful in reducing new HIV diagnoses among gay and bisexual men who are well connected to gay community in the inner city of Sydney, where we have in fact been the first place in the world to achieve that global target of virtually eliminating transmission. The task force is focused on ways in which we can expand access to PrEP. So things like telehealth models, nurse dispensing of PrEP, pharmacy dispensing of PrEP, and things like that. Another key area, though, is around HIV testing. And although we've done very well overall in reducing HIV, there are some people who are still diagnosed very late with HIV, which means they have not tested until the immune systems are basically failing and they become sick. So one of the strategies that is recommended by the task force is to embed HIV testing in medical settings, like community-based settings, and potentially opt-out settings, for example, in emergency departments.
And Dr. Keane, given that HIV can go undetected for so long, what are some things that GPs need to be aware of?
One of the key things is that anyone who is diagnosed with a sexually transmitted infection these days should be offered an HIV test. There are other common presentations which may indicate HIV, such as unexplained weight loss or fever, pneumonia or shingles.
And Dr. Giallonardo, let me bring you in here. Is there some reluctance among some GPs to ask for a full sexual history?
Yes, definitely. When it comes to sexual transmitted diseases, the conversation is always, it has to be about your sexual history, and not everyone is open or wants to freely talk about that, and that is totally okay. Especially, you might have a good relationship with your GP and are happy to talk about it. You may not. And so it's just also taking away the stigma of offering or discussing HIV. HIV can also come across as asymptomatic. It's most commonly asymptomatic in the early stages, so people might not have any symptoms. So very mild symptoms, like Phillip suggested, just a respiratory illness. And not everyone who might acquire HIV is an out gay man that is very active in the gay community. So the patients might not seem what someone might think an HIV patient would look like. We have seen in our research and is the changes in the demographics of people that are now more at risk of HIV, and this has changed in the last year, and something we need to be aware of.
And Dr. Keane, can you expand on stigma?
The bigger problem with HIV these days is that it is still highly stigmatized. We have prevention tools which are very effective at preventing HIV, but because it's so stigmatized, I think many doctors may be reluctant to offer an HIV test, even when they think that the patient may benefit from one. As Fran says, it's important to think about this as a viral infection. It can affect anyone. Certainly, fever of unknown origin or other common viral symptoms, it's worth considering HIV as a possibility.
And what population groups do you consider most at risk at this current time?
Well, certainly people from culturally and linguistically diverse backgrounds, particularly if they have recently arrived in Australia. What we know is that in many countries in our region in particular, there's not as great an emphasis on preventative health. So people may be less likely to have had an HIV test, less likely to be on HIV pre-exposure prophylaxis, and much more likely to have undiagnosed HIV.
And Dr. Keane, can you talk me through how treatment for HIV has evolved over time?
The old paradigm was that because HIV medication really was quite toxic in the early days, the paradigm was that people should wait until they had had a certain degree of immune system loss, immune function loss, until they began HIV treatment, and that at that point people thought it would make sense to start treatment. However, there was a big international study, a randomized clinical trial called the START study, which reported in 2015, and it showed that HIV treatment was beneficial for people with HIV at any stage of infection. So now the recommendation is to start treatment immediately upon diagnosis.
And Dr. Giallonardo, let me go to you. You wrote recently with Dr. Keane in Insight Plus about genetic-based surveillance, like molecular epidemiology, and how it can be useful in tracking the condition. At a high level, can you talk me through what this means?
After the COVID pandemic, more people are familiar with these terms of molecular epidemiology and phylogenetic clustering. These are research areas that have been in practice for HIV now for a long time. In broader term, what it means is we use the genetic data we get from the pathogen, the virus, to better understand the patterns of disease transmission. So when we look at these virus genomes, or what we call a sequence, we use these and use modern technique to generate different types of analysis. And this is what we would call a phylogenetic analysis. Phylogeny is simply a tool to form what we usually often use as an example is a family tree. So you try to understand which viruses are genetically more closer to each other than others. So basically you want to separate your siblings from your cousins in a very simple term. So we use this information to look at the changes in a population level, for example. For a country, how is the epidemic changing over time? How has it grown? Has it shrank? What are the characteristics of that? From this broader analysis, then we can look a bit closer and identify what we call a cluster, which is a smaller combination or a network of genome data that is genetically most similar to each other. So in our research, we use this cluster analysis to understand the changes in Australia or New South Wales in terms of HIV. We receive the sequence data and we combine them with the demographic data. So a person might be diagnosed and we know their gender or their geographic location, and in HIV commonly use the exposure risk factor. So that could be intravenous drug use or the sexual transmission. So if it's a gay and bisexual man, risk. And then we look at the cluster size and how long they have been active, in quotes. We try to understand and characterize if you can see patterns among clusters that are larger or smaller and how that has changed.
And just to reassure people who may be concerned about privacy, confidentiality is assured.
Yes, we take patient confidentiality very seriously, and we always ensure that this is the case. So we have formed our research project in collaboration with people from the HIV community, with public health representative from the ministry, but also we sought legal advice from HALC, a legal center specialized in HIV. With HIV particularly, it falls under a specific Public Health Act that specifies and rules who can generate data, who can collect the data, who can use the data, and what can it be used for. So we have to go through all these factors. We have to go through the ethics to be able to obtain the data and use the data. And it's all done and de-identified. So HIV diagnoses are not, especially in New South Wales, not a name. So there is never a patient name added to any of this data. It's all an identifier, and then we also link this using an external entity in the ministry, the Center for Health Record Linkage, that then anonymizes the data even further.
And looking from a health system perspective, how can this help inform public health strategies?
I think perhaps one good example of how it can be used in practice is if Fran sees that there is one cluster that is growing over time, then Fran can look at the characteristics of the people in that cluster and the sort of broad geographic region. That can help the public health response in that area in terms of working out where it has to push harder.
Dr. Giallonardo, what would you like to add?
What we aim to do with our research is to characterize these clusters and then identify the current gaps in prevention and see how we can then use this information to inform the public health, what changes are needed and how we can target measures better.
Yes, helping the public health unit act swiftly so there isn't a further spread of a condition or a disease. Dr. Keane and Dr. Giallonardo, thank you both so much for joining me today.
Thank you very much.
Thank you so much, Sam.
My special guests have been Dr. Phillip Keane and Dr. Francesca Giallonardo. Dr. Phillip Keane is a Senior Research Fellow at the Kirby Institute at the Faculty of Medicine at the University of New South Wales, Sydney, with major research interests in HIV testing, monitoring and evaluation. And Dr. Francesca Giallonardo is a Senior Research Fellow also at the Kirby Institute. She's a trained virologist and expert in molecular biology. You can read their Insight Plus article by clicking the link in the description of this podcast. You can find more podcasts on our website at mja.com.au or wherever you get your podcasts. Thank you so much for listening.